Good afternoon, everyone. Thank you all for joining us today for the Agency for Healthcare Research and Quality's webinar on implementing shared decision-making in varied practice settings. My name is Elena Fournier. I'm a health communications specialist at the Agency for Healthcare Research and Quality, and I will be your moderator for today. This webinar is the third in a series of webinars on shared decision-making in support of AHRQ's SHARE approach to shared decision-making. The SHARE approach is a 5-step process for shared decision-making that includes exploring and comparing the benefits, harms, and risks of each option through meaningful dialogue about what matters most to patients. The SHARE approach is presented in a 5-module, 1-day accredited train-the-trainer workshop at 10 locations across the country each year. To find out more about the SHARE approach, our workshops, and our previous webinars on shared decision-making, please visit www.ahrq.gov/shared decision-making. Our presenters and myself do not have any financial interest to disclose. If they do, they will be detailed in their own presentations. And this continuing education activity is managed and accredited by the Professional Education Services Group in cooperation with AHRQ, AFIA, and Academy Health, and PESG, ARC, AFIA, and Academy Health. Staff also have no financial interest to disclose, and there's no commercial support that was received for this activity. So today's learning objectives, you'll be able to describe the strategies for implementing shared decision-making in healthcare organizations, identify potential challenges to implementing shared decision-making and how to overcome them, and explain steps that healthcare organizations should consider in deciding how to implement shared decision-making. So I'm going to shortly turn it over to our first presenter, Dr. David Arterburn. Dr. Arterburn is a general internist and a health services researcher who holds positions as an associate investigator at the Group Health Research Institute and as an associate professor with the University of Washington School of Medicine in Seattle. He has been awarded numerous federal and foundation grants and has published more than 80 scientific manuscripts in the areas of obesity and shared decision-making. For the past decade, he has served as a medical editor for the Informed Medical Decisions Foundation, where he has collaborated on the development, implementation, and evaluation of patient decision aids and provider training programs to support shared decision-making. Dr. Arterburn, I'd like to turn it over to you now, and thank you for participating in our webinar today.
Thank you, Elena. It's a pleasure to be here today to speak with the audience. I first need to begin with some disclosures about my own financial support, and I have received both research funding and salary support from the Informed Medical Decisions Foundation, and have served, as Elena mentioned, as a medical editor for that foundation in the area of bariatric surgery and obesity for over a decade. The Informed Medical Decisions Foundation is a nonprofit organization that had received most of its early funding through partnership with Health Dialogue, which is a for-profit health coaching and disease management company. And as of 2014, the foundation is now a division of HealthWise, a nonprofit patient engagement and health information technology company. I should, as background, talk about who I work for. I work in Group Health. Group Health is a large integrated healthcare and health insurance and care delivery system in Washington and Idaho. We have nearly 600,000 patient members. More than 1,300 salaried providers at Group Health provide care for our members practicing in owned and operated clinics. We also have contracts with more than 9,000 healthcare providers throughout Washington state to provide care to members who are more remotely located throughout the state. The shared decision-making work that I will be speaking about today has focused primarily on our salaried providers in our owned and operated clinics. In 2009, group health leaders began integrated patient decision aids and shared decision-making processes into our routine specialty care practices. And we committed to significant organizational resources to support that work. And that's what I'm going to be talking about today. So why did we become interested in implementing shared decision-making in specialty care? It was motivated by a couple major issues. One was growing recognition that even within group health, we had unwarranted variation in the rates of many elective surgical procedures. For example, knee replacement. And this graph shows changes in group health's rates of knee replacement over time in different regions within group health. The central region near Seattle, east side in Bellevue, south near Tacoma and Olympia, compared to the state and other regional areas. And we had large variation, and that variation was persistent from around 2001 through 2005, which we thought was unexplained by the severity of patients' knee osteoarthritis in those different areas, but more likely related to provider practice patterns or practice differences. Another major initiative that happened in Washington State to motivate our work was that shared decision-making and the use of decision aids are the highest standards of care for informed consent in Washington State. In 2007, legislation passed by the governor recognized the use of shared decision-making along with high-quality patient decision aids as the highest standard of informed consent. And in 2012, Washington State passed additional legislation which has authorized the medical director of the Washington State Healthcare Authority, which purchases all state-purchased healthcare, to certify high-quality decision aids. And the process for certification is currently in development. So beginning in 2009, Group Health adopted an implementation strategy that was system-wide within our owned and operated system, where we focused on 12 preference-sensitive health conditions that were related to elective surgical procedures that we saw as being potentially high variation or high cost to our care delivery system. Further, we focused on some video-based patient decision aids, and I'll talk a little bit later why we made some decisions to focus on those particular decision aids. Our organizational leadership had to set the tone for why we were implementing this, and they saw this work as being potentially on a large cultural spectrum, where on the one hand, this could be something that was nice to do if you had the time and the inclination, versus on the other hand, you could see it as something where no patient should undergo a preference-sensitive procedure without documented evidence that they got all the information they needed and then had a conversation with their provider in which their preferences were documented before they made their decision. And this is the area where group health leaders were trying to push us. They were really focusing our culture change around a sort of imperative that this would be the standard of care within our owned and operated practice settings. How did they implement this change strategy? It began with the hiring of project managers who had experience implementing changes in practice throughout group health, who were assigned to carry out this work. They initially met with specialty leaders to identify both the specialty lead clinical chiefs and getting their buy-in about the approach, and then identifying other champions within the specialty to help spread the word and to move adoption forward. They worked closely with frontline staff to develop the workflow in each of the clinical sites to understand when the decision aid would be ordered and how follow-up would happen. They set a clear go-live date, which all the resources were made available for the launch, and then they initiated frequent reporting and process measures, which I'll talk a bit more about, in which providers got monthly feedback initially and later on moved to quarterly feedback about their use of the decision aid tools and its impact on decision making, and scheduled ongoing check-in points with the clinical leadership and with providers to help ensure that the practice changes were being implemented and stabilized over time. So again, coming back to how did we choose what decision aids we would implement? And we began by searching the Ottawa Health Research Institute's website for inventory of patient decision aids to look and to shop and to see which decision aids were the highest quality. We were fortunate in my own prior work to have an ongoing relationship with the Informed Medical Decisions Foundation, and through them with a company, Health Dialogue, to gain access to their patient decision aids during the first 2 years of our implementation process in the context of some research and evaluation work at no cost to group health. Subsequently, we purchased access to those decision aid tools. But we found them through the Ottawa Health Research Institute, and we cross-compared them with other decision aids that were available. And these decision aids in that database are rated on the International Patient Decision Aid Standards Checklist, or IPDAS, and they provide a score there on the content criteria, the development process criteria, and the effectiveness criteria, which allows you to shop around and cross-compare different decision aids and decide which one might be the right one for you in your clinical practice setting. So we adopted knee osteoarthritis and a number of other patient decision aids. We actually initially began with 13 decision aids, and this shows the list of videos that were made available to our patients and through a variety of different methods. One was that providers could point the patients to them online where they could go watch them streaming. And the second option would be that the patient could be mailed a DVD to their home with a booklet so that they could review the decision aid at home with their family. And you could see that the decision aids varied in length from about 30 minutes to the upwards of 50 minutes. Patients found these links to be acceptable in surveys that we reviewed with them, we conducted with them. Speaking directly about how we use the electronic medical record to support decision aid delivery, we had a number of different options, really 3 main options for providing these decision aids, videos, and booklets to patients. One was to, again, mail or order the DVD to be mailed to the patient's home, and that was done through the EPIC electronic medical record platform, in which we could, provider could type in DVD or SDM, and they could come up with the list of patient decision aids that they could then order that would then be mailed to the patient's home. Option 2 was to include instructions about how to access the decision aid in the ABS, or after visit summary, and that would show them how to view it online. And so in the patient instructions tab, they just typed in ABS DVD, and that would pull up the whole list of DVDs and their instructions for how they could access those videos online. And then finally, option 3, they could send a secure message, so it's like an email directly to the patient, inviting them to review one of these tools. And we had some standard messaging around that we built in to allow patients to receive those messages. And we had quite a bit of success, really, with ordering and delivering patient decision aids over the last several years. And since January 2009, we've delivered more than 50,000 decision aids in these 13 different topics. And this graph shows the trends over time, where you could see we had initially large uptake, and in some areas we've continued to have growth in the volume of decision aids ordered, and in other areas we've had some stabilization and even some decline. And a lot of that has to do with turnover in leadership and issues where we really have to continue to have an ongoing interface with leaders and the clinicians because of turnover, to make sure that this kind of care process is maintained. And so it's an ongoing process of quality improvement. We've also been tracking one important report that we've been giving to patients or to providers has been a defect measure. And so what the defect measure is the percent of patients who had one of these elective surgical procedures who did not receive a decision aid prior to the procedure being performed. And the blue line shows how we've performed over time, where we've reached down a plateau of right around 30% of our patients who had an elective procedure that did not receive a decision aid. our goal has been set at about 25%. And the reason we set the goal there is that we noticed that when we do chart reviews of patients who had these missed opportunities to receive a decision aid, that many of them had a valid reason not to receive a decision aid. They may have had another comorbid health condition that made them less eligible for a shared decision-making discussion about their health treatment decision. So we've done quite well in terms of driving down the defect measure as we have been reporting it. And one very helpful factor for us in implementation has been to, in the first year, we surveyed over 2,000 patients who had received the patient decision aid in each of the different specialty areas and gave the providers feedback from those surveys, where we found that more than 96% of patients who had reviewed the decision aids felt that they helped them understand their treatment choices, and 95% of patients surveyed stated that these decision aids helped prepare them to talk with their provider. So giving this feedback directly to the providers in the different specialties helped them to see the value added of ordering these decision aids for their own patients in their own practices. And we published a paper in 2013. It's actually Jamie King and Ben Moulton published an independent evaluation of our work, in which they identified some key factors that led to the culture change in our environment, including strong leadership with clinical champions, requiring all providers to watch the relevant decision aids, having a half-day CME with outside experts where we trained 90% of our specialty providers and surgeons around the steps of shared decision-making, having this monthly feedback to leaders and providers around the volume of decision aids ordered, the volume of surgical procedures and total costs of procedures that were occurring over time, and the number of patients who had surgery without receiving a decision aid. Finally, the satisfaction data that I mentioned. So we felt that each of these things really led to the culture change and the high degree of uptake of patient decision aid ordering that we saw within our population. So with this work, we demonstrated that large-scale implementation of patient decision aids is feasible. But there were still a number of challenges that we faced. And one of the main challenges was a cultural attitude among many providers that they felt that at the outset that they already did share decision-making. But many of us knew that it would look something more like this, where of course it's totally up to you, but if it's up to me, I would choose to have the surgery. And so really working with providers to help them understand what the difference between typical informed consent and shared decision-making really was a critical piece. And before I mentioned, we did CME training with providers. We also did qualitative interviews with more than 60 group health specialists to understand their vision of shared decision-making. And generally, their reviews were positive. They felt that using decision aids and shared decision-making process benefits outweighed any minor concerns they had about the data within the tools or the specific tools that were being used. They definitely felt like her patients were more informed, and they also endorsed the fact that it didn't take more of their time overall, just changed the quality of the conversations that they were having. Some decision aids were identified as being more difficult to implement than others. So, for example, implementing a decision aid for chronic stable angina in the cardiology practice seemed to be much more difficult than implementing the decision aids for knee osteoarthritis. And there are a number of different cultural issues around those particular decisions, not necessarily the particular specialties, but that particular decision that made it challenging to implement. But one of the key challenges was that many providers really didn't see a difference at the outset between just patient education and shared decision-making. So although they felt that the patients were better informed and they were more understanding, we also got feedback from providers that they weren't changing their practice. And we had further evidence that maybe our decision aid delivery was not quite doing everything that we needed it to do. And so one of the ways in which we collected some data on that is 400 patients who were facing knee osteoarthritis decision aids or decisions. We examined those who had received the decision aid and those who had not received a decision aid and their score on some key knowledge items that Karen Sepulchre and colleagues on the call today actually developed and validated previously. We found that receiving the decision aid definitely increased the knowledge score for our patients, But you can see that still only 43% of patients, or only 43% of the items were scored correctly for patients. So over 50% of the items were scored incorrectly. And as we looked at the different items that were scored, there were some important gaps, such as only 9% of patients of all respondents and 6% of patients who went on to have a joint replacement got the question correct about the fact that 5 out of 100 patients will have serious complications after knee osteoarthritis, a joint replacement procedure. And again, only about a quarter to a third of patients understood the fact that less than half of patients will need a joint replacement within 20 years after their initial joint replacement. So key knowledge deficits were observed, and we had key culture change barriers. And so what that has led us to conclude is, as was demonstrated in a editorial recently in JAMA by Hoffman and colleagues, is that there's a real interdependence between the intersection between delivering patient decision aids and having good patient-centered communication skills that leads to a high-quality shared decision-making discussion. And so on the one hand, you've got to have high-quality tools that can be implemented. The patient decision aids help inform and bring evidence-based medicine into the practice setting, but you've got to have really good provider training. And so we've been focusing a lot of our efforts now on training our providers to ensure that they have the skills that they need to have a shared decision-making conversation and to ensure that patients have the knowledge that they need in order to have a high-quality decision. The way that we have been implementing that currently is that we're using an online CME program that was developed by the Informed Medical Decisions Foundation and HealthWise, and we've been piloting that in the last year and expanding it this year into our entire group practice. Also, we've been developing an interface within our electronic medical record that would allow patients to have their knowledge assessed after reviewing a decision aid, and that information would go directly into the electronic medical record where they can review it with their provider at the point of care. So my key conclusions are that we had a number of key factors contributing to success, including strong leadership, financial support initially to help delivery of decision aids, a well-defined implementation and monitoring strategy, and an ongoing commitment to process improvement. But despite this large volume of decision aids, we still have some major challenges. Many patients aren't receiving decision aids that we're troubleshooting. More decision aids are needed to cover diverse topics that impact different aspects of our healthcare culture. There's large knowledge gaps that exist even among patients who receive decision aids, and we need to implement tools to help support providers and patients to ensure that knowledge gaps are covered. And we need to help providers be sure that they are confident in their shared decision-making skills and have the behaviors that are required for ongoing implementation of this work. So I just want to thank a number of funders as well as many leaders and implementation team members, including research advisors that helped us take this work to where we've been able to take it. And thank you.
Thank you, Dr. Arterburn. We'll look forward to talking with you more at the end of the presentation with some during the question and answer sessions. Just a reminder, you can ask questions in the Q&A box on the right of your screen, and we'll handle questions at the end after all of the presentations. So now we're going to turn it over to a duo, Dr. Karen Sepulka and Dr. Lee Simmons from the Health Decision Sciences Center. And I will first read their bios and then hand it over to them. Dr. Sepulka is the director of the Health Decision Sciences Center in the General Medicine Division at Massachusetts General Hospital and an assistant professor in medicine at Harvard Medical School. For the past 5 years, she has been leading efforts to integrate shared decision-making in primary and specialty care at Mass General Hospital and Partners Healthcare. Her recent research has focused on the development of survey instruments to measure the quality of decisions. Dr. Sepulka has been active in local, national, and international efforts to improve the quality of medical decisions, including the International Patient Decision Aid Standards collaboration. And Dr. Simmons is an internal medicine physician at Mass General and an assistant professor of medicine at Harvard Medical School. Her research interests include patient engagement in care and shared decision-making. She is also on the staff of the John B. Stoeckel Center for Primary Care Innovation and the MGH Health Decision Sciences Center, where she studies the use of decision aids to help patients and clinicians in the shared decision-making process. So now I'd like to turn it over to Drs. Sebelka and Simmons.
Great. Thank you so much. This is Lee Simmons, and Karen Sepuka and I are here, and really excited to talk with you all. We just included some pictures since webinars can seem impersonal sometimes. I just wanted to make a couple of notes about disclosures. Karen Sepuka does have salary support, just as Dr. Arterburn mentioned, as a medical editor for HealthWise, and I don't have any relevant current disclosures. So we wanted to give you a background about our hospital and our primary care network, and give you some framework of where we've done work with decision aid distribution, implementation, and shared decision-making training, and really the development of our shared decision-making program at Mass General. So we're a hospital that is made up of over 7,000 staff physicians and nurse practitioners. We have over 1.5 million ambulatory visits per year. 41,000 operations happen each year, and we have 18 primary care practices that are both on-site and then in our communities that are part of our hospital network. We run together a program called the Health Decision Sciences Center with the program of shared decision-making that works both in primary care and specialty care practices across our hospital. Our goal is that we get the right treatment to the right patient at the right time, and that we do that every time at our hospital. And our shared decision-making program has really three components to it. The first is provision of high-quality patient decision aids, making those readily available to our clinicians and to our staff members in multiple formats that work best for the practice and for the patient. We also do clinician and staff training in shared decision-making skills and strategies. And then finally, a large component of our program that's been a key to our success is a close relationship with our Health Information Technology Department and easy prescription of decision aids that we'll highlight for you shortly, as well as robust measurement and reporting back to practices about their use of decision aids. Just wanted to give you a bit of an outline about our volume. As you'll see here, just by the numbers, we're probably at the time of this talk up to about 25,000 decision aids that we've distributed in the last 10 years. This was our 10th anniversary, June of 2005 is when we started our program. At this point, we prescribe over 500 decision aids a month to our patients in primary care and specialty care. And our reach is broad. We've now had more than 800 unique clinicians and staff members who've prescribed a program. So made the couple of clicks in our electronic record to prescribe one of these programs to patients. And not surprisingly to us, and probably not to this audience, the programs that we offer 40 different video decision aids that are produced by Health Dialogue, including the ones that David Arterburn mentioned earlier. The most popular programs for a long time have been those that are addressing thorny, controversial questions or conversations that clinicians would like their patients to be well prepared for before they meet in the office. And these are topics including PSA testing for prostate cancer screening, advanced directives planning, colon cancer screening, and then probably influenced a lot by some special initiatives that we're doing, programs on knee osteoarthritis and then insomnia, one of our mental health suite of programs. So it's not been easy, and we wanted to share with you some of the challenges we faced in implementation, and these are a few of them. Some of our clinicians are very interested, but others rarely prescribe, so we have these super users really who were real champions for the programs, but we worried that the patients who saw the doctors who weren't as engaged or hadn't heard of us or had forgotten about us weren't having the same opportunity in our previously highly clinician-driven program to get to these aids. We also worried that our ordering system, being so heavily clinician-driven, was not really serving the needs of our patients as well as we might be able to. If clinicians didn't know about the programs or they didn't ask patients about where they really felt like they might need more support or more information, we worried that those programs weren't getting to the patients. Another area of challenge that we've worked to overcome is how to identify patients when they're really at a decision point. There are lots of methods using the electronic medical record to identify patients based on, let's say, a problem list or a diagnosis code on a billing sheet, but that may or may not identify them at the right time. Just because someone has osteoarthritis as a problem on their electronic medical record doesn't mean that they're really needing to or wishing to talk about knee osteoarthritis treatment decisions at this time. It could be an inactive or a really quiescent problem or real minor in the whole scope of things for them. And then finally, one of our challenges, especially in primary care in our early days, was we used these programs, clinicians prescribed the programs to patients, but there often was not a good closing of the loop, meaning that a doctor and a patient might have a discussion about a condition and a video decision aid might be prescribed. It would arrive at their home, but then we wouldn't necessarily know what the patients thought about the program. Was it useful as they made their decision? Sometimes we'd get that feedback, but it wasn't done on a consistent basis, and that concerned us, and it was an area that we wanted to improve on. To address, and next, Karen and I are going to give you 3 cases diving in a little bit deeper into these challenges. And I'm going to share with you the case of how we addressed the low prescribing practices and clinicians and how we made sure that we had good spread across all of our primary care practices and clinicians. Karen is then going to give you more detail on our work to tie decision aid prescription to specialty referrals and really help decision aids make the process of going from primary care to a specialist consultation smoother and a better informed decision. And then finally, the final case is about how we've harnessed patient input on what matters most to them at the moment to get the right decision aids to them at the right time. So as I mentioned, we started our work in 2005 and in one primary care practice. And then by 2006, we spread this to all 18 of our primary care practices. We had a process in place that really required, and as a primary care clinician, I'm well aware of the phenomenon of death by 1,000 clicks. We only had 2 clicks required to order our program. We made it very streamlined. You could access the order form either through the problem list in the electronic record or through a resources page, we called it, where you could access all the decision aids that we had available. And clicking on one of those sent an email to our centralized shared decision-making center where we took care of the ordering and packaging and mailing of the programs to patients. We had very steady use. When Karen and I came on board with this project, we noticed that the use was very steady, about 100 orders a month. But we saw that some clinicians ordered dozens of programs a month, and other practices never had any orders. And we thought that we could do a little investigation to figure out why that might be. So based on the survey we had done of primary care clinicians about what some motivators were for them to use the decision aids, we developed a 1-hour training session. And what we had found through our survey was that clinicians who had actually watched a program, a video decision aid program, were far more likely to prescribe it for patients. To prescribe any of the programs for patients because they knew the content, they were more familiar with it, it was less of an unknown. So we decided to incorporate that into our work. And then we also thought it would be useful to give them data at the practice and provider level about their prescription of the program. We held these 1-hour sessions during regular practice meetings, so we weren't asking anything new of our clinicians or extra. And we gave them an hour of CME credit for their attendance. In this 1 hour, we gave them an overview of the shared decision-making program, why we were doing it, how you prescribe, gave them that usage data, not for any other reason other than to spur them on a little bit to ask the doc in their group who prescribed the most, hey, how do you use that, or how do you find it to be helpful? And then probably most powerfully, we gave comments from patients and providers about how the programs have been helpful for them in their decision making, and those were quite powerful. Finally, we let the practice director select a video decision aid to watch, and a lesson learned, by the way, if you go this route. We had given some options: colon cancer screening, advanced directives planning, and knee osteoarthritis. As it turned out, it was far better to choose the non-controversial knee osteoarthritis because a group of primary care physicians was quite unlikely to argue about their favorite way to treat knee osteoarthritis, but they were very likely to have a heated discussion about colon cancer screening options. So I learned my lesson after the first 2 practice meetings and then gave them a choice between knee osteoarthritis and advanced directives. And then we had a little time for discussion. 15 out of 18 practices chose to host us, and we made the rounds within about 4 months. Here's some of the feedback we've shared with our practices, the feedback we get from patients and from providers. Patients really like the programs. We know that from surveys very similar to what Dr. Arterburn shared. We had very similar positive feedback about the programs when we surveyed patients. And what was really rich for us were the comments and the thank you notes we'd get from patients. This helped me a lot. I was nervous, but I'll get that colonoscopy, for example. Thank you very much for the website you sent me. I read the cath section with great interest. Now I understand the process better. That was actually one of my own patients who was going for a diagnostic cardiac cath for angina. We also heard from providers that they found it useful. A lot of our providers were not surprisingly afraid that this would add a lot of extra time or make the visits really long, and it didn't. They found that these were good for patients who had high literacy levels, lower health literacy levels, a couple of different ways to access information. They could watch a video or they could read a booklet or both. They felt it changed the tone of the conversation. This is, to quote, less about fear about what's causing the back pain to a focus on what can we do to help you manage this pain and function through it. We were really pleased that our efforts of reaching out to the practices in person, going out and making the rounds, led to more than doubling of our orders. We found that not only did the orders double fairly quickly, but they stayed at a very sustained level, the high level. We think that probably one of the biggest factors, at least early on, was the comparative data. They found it helpful to see that some docs prescribed a lot more than others, and some of our practices who never used the programs asked questions about, well, what did this health center find it really useful? Maybe we can try that too. I'll also emphasize that a physician champion role was important. And at many of our practices, there would be 1 or 2 clinicians who were the highest prescribers. And contrary to what some of our practice directors had said, which was, I wonder why she prescribes so many programs. She's one of our best communicators. She doesn't need a video to communicate information. In fact, it was great leading by example that these doctors who were seen as great communicators were also using these aids, and that seemed to help a great deal. And then finally, in follow-up, we continue to reach out to our practices with quarterly newsletters providing that same comparative data, as well as updates about new programs that we have available, training opportunities, and other items of interest to the groups. We've continued to do training about every 2 years. We found that seems to be the right frequency. We don't want to saturate them, but every 2 years allows us to train new doctors and new staff. One big change in our training over the last 5 years is that now we train the entire team. So our medical assistants and our coordinators are just as up to speed on the use of the shared decision-making programs as our clinicians. And Karen's going to give you an example of how a team has engaged in this work. So I'm going to turn over to Karen to tell you a little bit more about some of our practices.
Well, thank you, Lee, and thank you for inviting me to come talk. This is Karen Sapuka. So the second case that we wanted to share with you really did come out of some of those meetings with our practice groups where the clinicians were very excited and interested in the decision aids, but also recognized that they were somewhat in the way, and they wanted to figure out were there ways to automate the delivery and get these out to patients that didn't rely on them having to remember in the visit. And so we did have a goal to take advantage of our electronic medical record or other health information technology applications to really support and assist in the delivery of these decision aids. In one early project, and this is sort of a cautionary tale, and this was before Lee and I were here, but the folks running the project were really thinking about this and decided to try and send decision aids, identify patients who might be eligible through the electronic medical record. So they were looking at problem lists, they were looking at claims to try and find people who might have the right diagnosis or disease. And then they did a very large mailing of decision aids. So they got out thousands of these programs, but I think overall it was sort of seen as somewhat of a disaster. We got feedback from patients. They were wondering why people were sending them these tools and these educational materials when they weren't really making a decision. Or we got even more concerning notes from patients who were sent a program that really wasn't even relevant for them. So for example, one of the ones that got sent was a program about treatment choices for uterine fibroids, and the woman had already had a hysterectomy, which then makes the patients feel like we're not really taking care of them if we don't understand, who they are and what their path has been. So we were very tentative in future efforts to ever do sort of blanket mailings of decision aids, although it sounds great and our tech guys always want us to do that, or at least it comes up often in meetings with some of our health IT folks. We really want to make sure that we have a more nuanced approach and are really identifying patients who actually need the decision aid and who are actually at a decision point. And so one of the things that came up as a potential great trigger was focusing on specialty referrals. There's been a lot of work in our patient-centered medical home to try and figure out how do we strengthen our ties between our primary care and our specialists. In Boston, there's lots of different specialists they could refer to outside of MGH that are just as close. And we want to really think about how can we create, more of a team and more of a coordinated care here within our center. And the nice thing is that referral to specialists for many chronic conditions like osteoarthritis or other topics really does indicate a decision point where someone might be thinking about more extensive or more intensive treatment. And so it might be actually a great time to link the decision aid. And so we were able to do that. We have an electronic referral system that works for our internal referrals from our MGH providers to MGH specialists. And when the referral reason was, for example, for a herniated disc or a spinal stenosis or a knee arthroplasty or hip arthroplasty, a question came up on that referral form asking primary care physicians, did they want a decision aid to go with this referral? And what we found after we rolled that out was about 2/3 of the referrals really now do have a decision aid that are sent to patients because of that trigger. Now, as we are an open system, so we don't only have people coming from internally. Our specialists were very excited with this program, but also recognize that actually a lot of the patients coming through aren't coming from MGH providers. And so they were wondering, how do we think about supporting all of the patients coming in to get this good information beforehand? And so we've also been working with the specialists and their staff to try and figure out ways to do that. In several departments, most notably our spine and gynecology, they have triage nurses. And so we trained the triage nurses. We had them watch the programs, so they were very familiar with the content. And so they now, when someone's scheduling an appointment and they're taking the intake, if it seems like that's an appropriate program for the patient, they will just go ahead and order it for the patient in advance of the visit. So we've worked with the providers so that they have made it clear that they would like that to be the process and the workflow for patients coming in to be seen. And so that's been working very well. We've been, collecting feedback on how this is going and, have gotten very positive feedback from our primary care physicians and staff. They very much like the connection to referrals and feel it's a great way to get people at the right time and to get that information. And they like the reminder. I know sometimes we hear about flag fatigue, but this is one, we didn't get any fatigue from it. They actually really liked hearing from it at that time. And then our specialists actually were very interested and excited, and they like to have the well-prepared patients. So they really like it when patients get these in advance. The patients also really appreciate getting the information in advance. We had done a project with some of our specialists in orthopedics and they were sending them out after their visit with the patient when we had first started because we hadn't quite figured out the workflow to get it to patients beforehand. And we got several notes back from patients saying, oh my gosh, this is great information, but now I have so many questions, and it took me 3 months to get in to see the orthopedic surgeon. I don't know, how do I get my questions asked? So patients were very appreciative to get the information in advance of the visit, and we found that they were very highly likely to use and review the information. This also did, highlight some issues actually for us with the referral process at MGH. And it was, interesting to see what the assumptions were on who the patients were that were coming in, what they wanted. When we first went around to meet with the specialists and their staff, they had assumed or thought that, patients were coming to see the orthopedic surgeon because they really wanted surgery. And they were planning to have surgery. Why else would they come to the surgeon? And we realized that, when we were talking to our primary care physicians, it was more that, they thought that some of the non-operative therapies hadn't been working so well, so maybe it was time to be evaluated or to consider surgery. But it certainly wasn't because they had already made the decision to have surgery. And, we also found that actually many of the patients that were getting referred never ended up with a scheduled appointment. And so I'd done some work trying to figure out from the primary care perspective, when you're making that referral, how engaged are you with the patients to make sure that they really do want to go ahead and have that specialty referral. And then it also brought up some questions that we're trying to figure out now, which is if patients watch this program, realize that they don't want surgery, should they still go and see that orthopedic surgeon? Or is there something else that we should be doing? So we don't necessarily want to waste either the patient's or the surgeon's time and make sure that we're getting very well qualified people in and through our system. So these are all issues that are coming up now, and we're trying to think about how do we make sure we're managing referrals and getting people to the right resources. So our last case that we want to take through really focuses on harnessing the patient's power. When we started this project, we really had heard some concerns and sensitivity from the clinicians that they really wanted to be involved and know what information their patients were getting. And so we did start with a very clinician, maybe paternalistic approach to delivering the decision aids. And this last case, we'll talk about maybe flipping that a little bit on its head. So in our primary care practices and actually across our hospital, there's a large effort to improve the care for mental health. So we've been doing a lot more with depression screening and management in the primary care practices and providing support for our primary care practices to do that. So this case is just going to be an example of what one of our community-based health centers has done. And this health center has about 10 physicians and several medical assistants, and they're really working to become a patient-centered medical home. And so they've been working to see how can we integrate shared decision-making within that team. So there was a lot of interest in shared decision-making. The providers really wanted to think about how to use decision aids in the practice, but this was a very low prescribing practice. They rarely ordered programs. So one of the nursing leaders really was interested in trying to take the lead and figure out how could they improve the patient education process and how could we tie it to this other initiative that's ongoing, which is in mental health. And we noticed that we have 3 programs that are relevant to mental health: treatment of depression, treatment of anxiety, and insomnia. And so they had figured out a workflow where the medical assistants actually were going to be offering all the patients getting screened with a PHQ-2 at the annual visits. And if that PHQ-2 it was positive for depression, the patients were offered an order form for the mental health program. So this was sort of putting this in the hands of the patients. Do you want this information? And it was really just focusing on the 3 mental health programs. Now, some of the lessons learned here with the patient-triggered ordering, one thing we found was actually that the number of PHQ-2 screens that were positive was pretty low, so less than 5% of the patients. And over about a 6 to 8 week process where we were just piloting this, only 19 programs were ordered by patients. So it wasn't a huge success, and in large part because not very many people were even given the opportunity to order the programs. And so then we met with the medical assistants, and they said, well, why don't we just offer this to everybody coming in for an annual visit, kind of regardless of whether that PHQ-2 was a positive screen or not. And then we ran it for that process for about 6 to 8 weeks, and what we found was there was about 200 mental health programs ordered. just in that same period of time. So more than an order of magnitude difference. And the programs were, anxiety, insomnia, and depression, but mostly the anxiety and insomnia programs. And so what we find when we open this up to patients is that patients are often very eager for this kind of information. And these are not the kind of programs, if you remember from one of the earlier slides we presented, these were not the programs that our physicians are typically ordering for patients. But when we think they're ordering the PSA, colon cancer screening, advanced directives. But when we open this up to patients, there's actually a real need and desire for this. So just to wrap up, so some of the lessons learned here, I think a provider-dependent workflow, this is one practice that had very, very low orders, really may be limiting and underestimating what the patient's desire is. So thinking about ways to open this up to engage patients in the ordering is important. And I think also just focusing on, certainly with the patient-centered medical homework, all of the, members of the clinical care team really can participate in the workflow. The medical systems really took ownership of the process. The nurses were really involved in sort of spearheading this, and were also very crucial in suggesting improvements to make this work. So I think as you go through, hopefully we'll have some time at the end with the discussion, to think about how some of these cases that we've sort of been dealing with are similar or different to what the folks on the webinar might be thinking about in their own experience, how they're working through things, what else ideas they have might help conduct the shared decision making more routinely. Some of the things that we're thinking about are documentation challenges. So, for example, our electronic ordering system, a note is automatically placed in the medical record that documents the decision aid was sent, but we're trying to figure out how do you document actually that the shared decision making happened. So that, we know how the material was sent, but we're thinking about documentation for shared decision making more generally. So just wrap up with what's ahead for us. So we have been working with Partners Healthcare. Mass General Hospital is part of a larger organization called Partners Healthcare, which includes 7 hospitals and more than 230 primary care practices. So a significant jump for us in terms of the scope and scale of this dissemination. So we're hopefully going to be learning more as we move forward with that. I think, for folks thinking about how do you get this funded, where's the support coming for this? So our organization is coming through population health management within Partners Healthcare. So they have both contracted with Health Dialogue to get decision aids, as well as providing support and funding for project managers and others to get this implemented. We always have new challenges. Our IT applications, as we expand across partners, right now there's at least 4 different electronic medical records, soon to be 1, but that transition over the next several years is going to be a big one. And thinking about aligning incentives and measurement so that we're all supporting the same goal of really matching that right patient to the right treatment at the right time. So I think with that, I will wrap up and thank you.
Thank you both for sharing those lessons learned in those cases with us. Really appreciate learning about that, and I think we'll have a good discussion again at the end. Just a reminder, you can submit your questions in the Q&A box on the right-hand side of your screen, and we'll save those questions for the end of the presentation. So we have one more presentation for you, and we have another dynamic duo. We have joining us, we'll go to the next slide, please. Thank you. We have Lyle, or LJ Sagnan, and Mr. Mark Remacher, both joining us from the Oregon Rural Practice-Based Research Network. And Dr. Fagnan joined the Department of Family Medicine at Oregon Health and Science University in 1993, and in 2002, LJ became the director of the Oregon Rural Practice-Based Research Network. LJ maintains an active family medicine practice and was named as the Family Doctor of the Year by the Oregon Academy of Family Physicians in 2005. LJ's research portfolio includes studies and publications related to population-based health, dissemination and implementation of evidence-based medicine into practice, quality improvement, and rural healthcare systems. Mr. Remacher is a research associate at the Oregon Rural Practice-Based Research Network that provides quality improvement and research support to clinics in the Pacific Coast region of Oregon. Prior to working at ORPRN, he spent 2 years working at a practice-based research network based out of the University of Wisconsin-Madison. So now I'll turn it over to Dr. Bagman and Mr. Remacher. Thank you guys for joining us.
Great. Greetings from Oregon. We have received some research funding from the Informed Medical Decisions Foundation. As David had stated earlier, they've really been quite helpful in stimulating the shared decision-making movement across the country. Mark and I will share 4 of our shared decision-making projects that we've conducted in the past 6 years. And so we're going to go through these 4, but I wanted to provide some context about the network. The Oregon Rural Practice-Based Research Network is a PBRN. PBRNs are networks of primary care practices that really set out to link questions from practice to answers from practice. And the Agency for Healthcare Research and Quality has been a strong supporter of PBRNs, and over 130 primary care PBRNs are registered with AHRQ. ORPRN is currently comprised of 60 primary care practices, predominantly family medicine, with 170 clinicians that serve 300,000 rural Oregonians. So 1 in every 5 rural Oregonians receives their care in an ORPRN-affiliated practice. Our practices historically have been small to medium-sized independent practices located across the state, primarily rural. These practices have little support from a health system mothership, and they have a menagerie of EHRs and very limited IT capabilities. Participation in our studies is on a voluntary basis. As we go through these projects here, there are a few key points I want to mention and lead into this. And the first is that primary care clinicians in their practices feel that shared decision-making is the right thing to do. As David's great slide showed, many docs state that's the way they've always practiced. The second point is that changing behavior is hard to do. Voicing support for shared decision-making does not translate into behavioral change during the patient-practice encounter. Behavioral change needs to occur across all levels, clinician, staff, and patient. Our study implementation of shared decision-making involves all 3 levels, ideally working together. And third is that patients really like shared decision-making, and getting patients involved in practice change is really effective. They want to help their practices improve. They consider their practice as part of their home. And the last point that will become evidence as Mark presents the work that he's been involved in is that an outside facilitator is needed to keep shared decision-making interventions on the practice radar screen. We call our facilitators in ORPRN Practice Enhancement Research Coordinators. Without PERC involvement, practices struggle with shared decision-making. So I want to go on and talk about a few of the projects. The first one is the Informed Medical Decisions Foundation project. We were fortunate to link up with, be a part of 10 demonstration sites implementing shared decision-making decision aids into day-to-day care. As you can see from this map, a lot of these places are large health systems and academic. So we feel like the caboose on the big train doing this work, and we have, I think, a fairly unique setting. In conducting this work and looking, these are examples of some of the categories of conditions that we had decision aids for. And we asked the question was, how useful was the program in helping you prepare to talk to your healthcare provider? And And so the blue is ORPRN. I don't know what color it is on yours. It's kind of an orange on mine. Are the other demonstration sites. But uniformly, patients felt like this was important to do and it was useful, and they valued it quite highly. We found that, as I mentioned, in implementing decision aids in these 6 practices, we conducted this work over about 4 years. Facilitation was needed, and facilitation at a lot of different levels. You needed patient buy-in. We found one practice was able to use their patient and family advisory council quite effectively, and they actually designed this prescription pad that you're looking at here. This was the PFAC, or the Patient and Family Advisory Council, that created this, and they had a kiosk out in the waiting room. And so they were a big part of the implementation in this particular practice in Northeast Oregon. External support through practice facilitation through our PERCs is really key in terms of protocol implementation, developing a distribution process, and really sharing data. We collected data on the decision aid distribution and the return of questionnaires with the practices. It took that PERC involvement. We created a toolkit based on working with these 6 practices, because we felt like these small to medium-sized practices had a different story to tell. And this is the site for the toolkit. We actually tested it with other practices that were getting involved in distributing decision aids, and people have found it useful. A more recent project for us is, some of you may be familiar, is the CMS Comprehensive Primary Care Initiative. Oregon's one of 7 markets. Most of these practices are small practices, and they have 9 milestones to meet. Milestone 7 is implementing shared decision-making decision aids. So we're in the 3rd year of this 5-year program, and in the first year, the practices were to select a condition for which they would implement a decision aid and track the distribution of that decision aid. Year 2, they were up to 2 decision aids, and year 3, they're to identify 3 conditions and 3 decision aids. Well, how did they do? This is pretty much what I was talking about before, and I'll go into how they did here. This is our Oregon results, and you can see that it's been a challenge. It's been a challenge to integrate the shared decision aid into the clinical workflow. And the January 2015 evaluation report on CPCI reported that there's been limited success in identifying and incorporating shared decision-making tools and processes of care. This has been really hard work for the practices to do. With that, I'm going to turn things over to Mark Remacher. Mark's our PERC, and it's really the PERCs that make things happen with our shared decision-making study. So, Mark, I'll have you take over. And I got to move the ball here to get it to you. There we go.
Thanks, LJ. Actually, I don't think I have control of the slides yet. There we go. As LJ mentioned earlier, I think I want you all to keep in mind that the fact that close to 80% of the Oregon CPC clinics that did engage in shared decision-making did not integrate it into their clinic workflows. And this really sets the stage for what I'm going to talk about for the last part of this webinar, which is how do we integrate a sustainable shared decision-making practice into small primary care clinics. So over the past 2 years, ORPRN has been involved in 2 comparatively smaller scale shared decision-making projects These are projects that involve 3 to 4 clinics as opposed to the 67 that were on board for CPC. And because we were working so closely with these clinics, we were able to see firsthand what some of the specific challenges small rural clinics encounter when attempting to implement shared decision-making. So the first project that we're going to talk about, which we'll call MammoPad, and you'll see why, tested the utility of a breast cancer screening decision aid developed for an electronic mobile device or an iPad. And it was tested in 3 small rural primary care clinics. 2 of the 3 clinics that partook in this project were also involved with CPCI, and their participation helped in part to fulfill that milestone 7 that LJ talked about earlier. This is important to mention for 2 reasons. One, that those clinics had an additional incentive to implement MammoPad, and 2, that they represent a portion of the 80% of CPC clinics mentioned earlier that did not fully integrate shared decision-making tools into their clinic workflow. So given that the focus of this webinar is on integration of shared decision-making into the clinic practice, I don't want to spend too much time on the content of the DA, but broadly, it aims to heighten awareness about breast cancer screening and ensure that women who were above average risk of breast cancer were referred for appropriate follow-up. And also, it helps women of average risk make an informed choice about their screening. Those are some screenshots from the actual decision aid that you see. So after the patients viewed the decision aid, a customized report, including the patient's questions, concerns, and plans for screening, was automatically generated and emailed to the research coordinator, me, as well as the patient. And actually, if you're interested in reading more about this specific decision aid, we just found out last week that it's going to be published in an upcoming volume of the Journal of Women's Health. So how did we integrate? We can break this down into 5 steps, really. So first, we found the target population through medical chart audits, which required running a report using a pretty few simple criteria, like finding women between the ages of 40 and 49. Then we recruited patients from that list by calling them, explaining the project, and scheduling a time for the patients to come into the clinic to view the decision aid. When the patient arrived for the scheduled appointment, we explained how the iPad worked and then administered the decision aid, and we stayed in the room the entire time just in case any patients had any questions, and not many of them did. Once patients finished viewing the decision aid, one copy of the customized report was given to the patient to take home, and the other was scanned. Oh, sorry, actually, you'd like to see this report while I talk about this. So once they finished viewing this decision aid, the copy of the customized report was given to the patient, and the other was scanned into the patient's chart, and the provider was notified that one of the patients had just completed the decision aid. So kind of as a side note, scanning the decision aid into the patient's chart, while not an ideal method, it did function as a way to track who had seen it, which I think was a question that came up earlier. Finally, the patient, let's go forward here. Finally, the patient who was overdue on their mammography screening was encouraged to make an appointment with their provider to discuss their screening options. So this integration of this decision aid into the clinic workflow worked pretty well. We had close to 100 women view the DA over the course of a few months, but it wasn't sustainable. The ORPRN practice facilitators were responsible for a bulk of this process, and most small clinics don't have access to a practice facilitator yet. The clinic still had access to the decision aid when the study ended, but they didn't have staff to maintain the workflow. And this is an important point to illustrate because it really highlights the fact that just providing a clinic with a high-quality decision aid and a tutorial on how to locate patients and distribute the decision aid and document in their EMR is not sufficient. You really need to put in place a workflow that doesn't add to the busy clinic staff day, and it's totally attainable, in my opinion. Moreover, by actively recruiting patients, like creating registries and prompting them to come into the clinic to view the GA, we weren't really waiting for a natural decision point to arise, like administering the decision aid when that patient was coming in for her next well-woman visit. Instead, we forced the point by recruiting the patient, which probably wouldn't work in a regular clinic practice. Finally, while we have documented how many patients did view the decision aid, there was really no way for us to know how many patients closed the loop by communicating with their provider afterward, which is really a pretty important piece of shared decision making. So for the second project, well, the earlier one, the MammoPad project, it did involve integrating shared decision making into the clinic workflow. But it was part of a research project, and it came with a prescribed method for delivering the DA. So it didn't really allow clinics to exercise any flexibility in their implementation strategy. The Patient Experience of Care Learning Collaborative, on the other hand, which involved 6 small primary care clinics who attempted to integrate shared decision-making from the ground up, did. When I say the ground up, I mean we didn't supply them with any decision aids. Our research staff was not a part of their workflow. We just helped to facilitate their process. As part of the collaborative, each of the 6 participating clinics were asked to identify a multidisciplinary practice team, including at least an administrative champion, a clinical champion, and perhaps the most important here, a patient partner. Those clinic teams were expected to attend 3 in-person learning sessions where we discussed topics around shared decision-making and patient's experience of care. They participated in group calls and webinars, and they set at least 2 clinic-wide process improvement goals that were related to shared decision-making. Most actually did more than 2. So, at the beginning of the Learning Collaborative, we also included a fielding of the CAPS PG12 survey with some additional shared decision-making questions in order to measure the patient's experience with shared decision-making. So as I mentioned earlier, we did not pressure the clinics to implement shared decision-making in any specific way or use any specific decision aids. Rather, at our first in-person collaborative meeting, we had an expert presenter educate the teams on the main tenets of shared decision-making, and then we introduced them to the IMDS implementation error, which you do currently hopefully see on your screen, and worked with them to implement shared decision-making in a way that worked for their clinic. Interestingly, most clinics did wind up picking really similar QI goals, which included the ones you see here: increasing provider and staff awareness, increasing patient engagement, and finally finding and distributing high-quality decision aids. These teams may have picked similar goals because they were working together in the same learning collaborative and thus sharing ideas, or possibly because successful implementation of shared decision-making requires completing a certain number of steps, regardless of the clinic that you work in. So you could forward the slide. So the first goal, provider and staff awareness, we figured out really early on in the collaborative in-person discussions that most staff may not be aware of shared decision-making, and some providers may actually be resistant to it. So we decided that a smart initial step in integrating shared decision-making into the clinic is to make sure that the entire staff, especially the leadership, was aware of what shared decision-making was and how it differed from patient education. To accomplish this, we organized a time during the clinic's all-staff meetings for Dr. Fagnan to come down and introduce the providers and staff to the concept of shared decision-making. It's important to mention that the meeting wasn't completely didactic, though, as we allowed for time for the providers and staff to ask questions, voice their concerns about barriers, and give their suggestions for how to successfully integrate this into their clinic. And that really gave them an active part in the project, even if they weren't formally on our team. You could forward the slide. For the second goal, patient engagement, there was some consensus among our patient partners that patients don't always realize that they do have a voice in their healthcare. So we decided that our next step should really be to promote shared decision-making among the patients. If you want to forward the slide. In an attempt to promote patients to take a more active role in their care, we posted a series of shared decision-making flyers that we borrowed from the Health Foundation's Magic program out of the UK in the clinic exam rooms. And the flyers that you should see on the left prompted patients to ask 3 questions. What are my options? What are the possible benefits and risks? And how can we make a decision together that is right for me? Then on the right side, we also displayed the clinic results from the CAPS survey to show patients that their clinics are interested in what they have to say and that the clinic wants to make changes in that area. Can I forward the slide? So for the final goal, clinics wanted to administer some decision aids. So after completing those first two, they really wanted to move forward by getting decision aids into patients' hands. We spent some time with each clinic team searching for decision aids. Most clinics actually did have access to some pretty nice decision aids, but they were buried in the EMR. So if you're searching for decision aids out there, look in your EMR again, because they're probably hiding in there somewhere. From there, the clinics tapped their administrative and IT staff to run some reports locating the populations that they were targeting. And then each clinic really had minor variations in how they chose to distribute their decision aids. But the most successful groups leveraged their EMRs and patient portals. So, for example, one group who chose to focus on colonoscopy screening would run a report every couple of weeks that pinpointed patients who were coming in over the following 2 weeks for a clinic visit and who were not up to date on their colon cancer screening. These patients were then sent a letter via the patient portal that had an embedded link to a decision aid. And this method, it gave patients access to the decision aid 2 weeks prior to their visit, which allowed for more time to review the information and have a discussion with any family members that they may want to include on their decision. Turn it forward with the slide. We did have some barriers to implementation. Time, which is no surprise that this was a barrier mentioned by most staff, but it doesn't really have to be an issue. We need to think of really innovative ways to distribute decision aids without adding more work to an already overwhelmed clinic staff. Provider engagement, which I think was brought up by every group today, was also an issue. While having an expert presenter like LJ introduce the concepts of shared decision-making to the clinic staff during their meeting, it did pique some interest in some of the providers, but there were still some providers who were really resistant. And shared decision-making is not easy to do without an engaged provider. Finally, the patient engagement piece. We were told by patients in both the MammoPad project and the Learning Collaborative that they either weren't always aware that they had options or they weren't comfortable addressing them with their provider. Forward the slide. Some successes that we had were introducing shared decision-making to a staff who wasn't aware of it, and clarifying the philosophy to those providers and staff who thought that it was actually just patient education. Also, by digging through the EMR, we did find that most clinics did have access to DAs, which is nice. We got the ball rolling on engaging patients, and in some cases, we leveraged our technology to distribute decision aids without having too much of an impact on the clinic staff. Turn forward the slide. Some of the lessons learned. This is really hard to do. It requires a lot of multiple simultaneous changes to a clinic workflow, like getting the provider and staff on board and having access to really high-quality decision aids and tracking mechanisms, and finding ways to better engage your patients. We did find that facilitation was really helpful, like LJ mentioned earlier. So having a researcher set shared decision-making as a priority agenda item and showing up monthly to make sure that you're on track seemed to be really helpful. Facilitators can also help to fulfill the specific needs of the clinic by connecting them to resources that will push their specific shared decision-making agenda forward. Including a patient was really critical to our success. They helped us get into the mind of the patient, tell us what they would want and would not want, and what they would feel comfortable doing. And then finally, this takes time, so be patient, because culture change likely won't happen overnight. So jump forward the slide, that's what we've got. Thanks a lot for your time.
Thank you both. A lot of really great information there. So at this point, I'm going to tell you a little bit about obtaining your CME and CE credits before we go to the question and answer session. If you'd like to receive your continuing education credit for the activity, please visit this website. I believe it will also be emailed to you at the end of this. So I don't think you necessarily have to scroll it down really quickly. So now we will go to our questions. There's about 7 minutes left, I believe, yeah. And so we have several questions in the queue already, so we'll get to as many as we can. So let me start with a question for Dr. Arterburn. The first question is, With the distribution of decision aids, the electronic decision aids, does this serve as a mechanism to confirm that a patient has received shared decision making? And if a patient opted for a hard copy version of a tool, how would that be tracked?
Okay, good question. So we use the electronic medical record to confirm that they had received a patient decision aid, and that was one of the things that we could track, and it was relatively straightforward to track if the patient had, if the provider or one of the care team members had ordered the decision aid from the electronic medical record. It's pretty easy to see if that has been done. But we actually documented shared decision-making conversations in a different way using smart phrases. So these are dot phrases that we can implement in Epic, and we have those as well available to providers. But that's actually, it's a longer-term goal that we're working on, and I would say that we have less documentation of shared decision-making occurring than we do have documentation of decision aids being delivered. So I think that's probably one of our main challenges. If a patient opted for a hard copy version of the tool, that was the Epic order. So that was tracked directly in the electronic medical record as an order.
Okay, thank you. Okay, I have another question. This one actually came in right after Dr. Arterburn's presentation, but I think any of you can answer it. Have any of the providers reported situations where they attempted shared decision-making and the patient insisted on a treatment that the provider did not feel was indicated? What tips do you suggest to help providers handle these types of situations? Karen, do you think you could answer that one?
Yeah, I think Lee and I can jump in on this one, because it's certainly, a scenario. There's that scenario, and then the other scenario we hear a lot from our providers is, what do I do if the patient just asks me for the recommendation and they don't seem to want to be involved in shared decision making? So there's sort of two different issues that often come up. So I'll let Lee sort of give the provider perspective on how to handle that.
Yeah, so we hear this a lot, and we hear this a lot from providers actually about decisions and conversations where we actually don't have decision aids too. So this is certainly a common concern, and what we emphasize to our clinicians and to our staff is that what the shared decision-making process can do and the decision aids can do is make this more of an ongoing conversation. And you can feel more comfortable as the clinician that you have given all the information that you know and you have to the patient to help them with the decision making. And you can feel more assured than you would have if they were making a decision not recommended than you would if you hadn't given them that information. So there's not a perfect answer here. It's still challenging, but what we hope is it eases some of the stress that may be the reason they're making that decision that you don't particularly agree with. At least you can feel comfortable that it's not because of a lack of information or you provided it in multiple different formats. So that's how we emphasize that challenge. I'm going to let Karen address the question of what to do when people really want the doc to make the recommendation.
Yeah, and just to pick up on what Lee was saying, one of the things we often encourage the clinicians to do if someone comes in with a strong preference for a certain treatment is to maybe just take that as a starting point for a discussion. So what do they understand about the benefits of that treatment? What do they understand about the harms of that treatment? And that'll give you a sense for what the patient's sort of goals are. And there might be that there are other things that come up that say, well, if this is really what you're most worried about, then, this other treatment might be more, appropriate. And so really we encourage people to take that as a starting point for a conversation to explore sort of where they've been going for information and what they have. And what they understand, in terms of that. I think the other thing that we do when we're, when patients come in and aren't very engaged and don't seem very engaged, certainly the decision aids help a lot with that and getting patients ready to ask questions and answer questions. And so as Lee, mentioned, sometimes if the big decision, we'll recommend that our providers don't have to do it at that same visit, and that they can give patients some information and time to take it home. We also, model for our providers. It's not that they can't give a recommendation, but often what they do is, they might give, here's 2 different patient cases that have chosen different options, and here's why they chose those different options, as a way of really illustrating to the patient that there's different paths to go, and then exploring with the patient, again, starting a conversation with them to explore what their needs might be and which way may make sense for them.
Okay, thank you so much. It looks like we're out of time for additional questions. I think what we will try to answer some of these questions and perhaps post them to our website at www.ahrq.gov/shared-decision-making. Look in a couple of weeks for this webinar and the materials to be posted there. So thank you again, and remember to go get your CME credit that's available. And thanks again for attending today's webinar.